So policies and procedures or practices that truly get at that advantage slash disadvantage, right? So that can look like HIV criminalization laws, so like laws specifically negatively impacting people living with HIV. That next level of HIV stigma begins to touch on person-to-person interactions or interpersonal. And that is like verbal or nonverbal communication. That could be micro or macro aggressions or even hate crimes and assaults. We can see this interpersonal language play out through like dating profiles on different apps. So that could show up like folks saying, I'm negative and you be disease and drug free as well. So like that concept of serial sorting or choosing partners based on HIV status truly goes into that level of stigma. And finally, when we think about the individual level of stigma, that is the actual individuals or actual persons who are experiencing these stigmas. And we can see individual levels of stigma let me start that sentence over. So we can conceptualize or we can understand stigma from an anticipated standpoint. That means as a result of me living with HIV, I know my provider, I know my friends, I know my community will discount me, okay? When we think about enacted or experience, again, that could be going to a clinic or organization that only serves people living with HIV on Tuesdays or Thursdays, And finally, when we look at internalized stigma, that is seeing a devalue of self as a result of me being positive, okay? Again, at any time, if you have questions about these levels of stigma, feel free, to lift them up. We really have the opportunity to have a deeper conversation tonight. So with that level setting, let's jump into the conversation. We can go to the next slide. And these are just some prompts for tonight's conversation. So do not feel, we have to move in order from 1 to 3. Feel free to jump in at any point in time. But prior to jumping in, would anyone like to add their thoughts on HIV stigma?
Hi, this is Zena. I didn't know it was right after Labor Day that I said I was going to be speaking to you guys. It took every ounce of my being to get it together after that white party, 3:30 in the morning. So, needless to say, I am here. So I am speaking. So what I want to talk about really is the foundation of where I think a lot of stigma is coming from. What I realized is that when we talked about stigma, this is like maybe 25, 26 years ago, we was really talking about stigma as it relates to infected individuals, but not the psychological that it feels with affected people who are living or dealing with people who are HIV positive. So when we talk about the stigma, we also want to talk about the stigma and how it carries in that secrecy, shame, and guilt passed from generation to generation because it was never addressed at the beginning of time when they were HIV positive. So I wanted to make sure that we talk about the affected population when we talk about stigma, because there is a lot of stigma that take place where now the mothers are having the children and they're trying to figure out how to disclose to their children that they're positive, because they never was able to do that to their own kids themselves. Their mothers wasn't able to disclose that to them themselves. So, when we talk about that, I really want to talk about a lot of the psychological things that happens with people who are psychologically affected when we talk about prevention.
No, I think that's an excellent point, Zena. And, you truly begin to shed light into some of the communities that are most impacted, when we think about stigma. Specifically, you made mention of, vertical transmissions. So that those are mothers or childbearing persons. Uh, you got to use the correct language. Childbearing persons living with HIV, potentially passing it on, especially if one is not in HIV care and HIV treatment. So thank you for that. Would anyone else like to add any, level setting, before we continue the conversation?
Well, Daniel, I think too, if we're going to talk about stigma, we also have to look at the result of stigma, which is fear. Oftentimes you have community stakeholders, clients who will tell you that they may not feel comfortable going to this place for one of two reasons. One, it could be the provider's own internalized stigma, or it could also be, due to that fear that is caused by stigma, they're scared that everyone else is going to talk about what they're going through. To give you an example, a broad example, I had a client myself, and they told me they didn't want to go to a certain facility not because the people there, but because the clients themselves who get services, in this client's exact words, them people talk too much, and I don't want people knowing my business. So I think we also have to talk about that as well. I think it's a good intersection on how we can address the result of that stigma, which is fear, in trying to help our clients figure out some way to feel more comfortable in getting the services that they need.
No, I think that's a great one. Come on, Dr. Virgil, go ahead, please.
Yeah, since I was really involved with treating individuals with HIV, starting in the 80s, back before HIV, what we knew actually the cause. And I've been able to observe stigma over a long period of time. And Tito's actually correct. Stigma, ultimately, when I look at it, it comes down to the issue of fear. And to watch how the issue has come from the first fear that I saw major as it related to HIV was that fear of dying, the disease itself. Because, early in the disease, once you got the disease, it was a diagnosis of death. And we call that. And one of the first things we try to do as providers, and I remember my professor was teaching me, we're trying to keep these people alive for 6 months, individuals with HIV alive for 6 months, so that they can actually settle all of their issues with their families, their friends, any kind of business that didn't get completed can be done. That's the best thing we can do for them. And at that time, it was, I don't want to have HIV, I could die, etc. But then over time, the greater fear became, again, that fear of individuals who are different from myself, labeling those communities. It's the communities of individuals who are drug addicts. It's the communities of individuals who are gay, who are then having sex with men. And then as we went along with it, and even as we've gone along, some of those same issues of stigma still exist. And I just want to say that looking at the politics of everything nowadays, we're starting to see those groups of individuals that have the negativity towards individuals that are different than themselves, the gender issues, and individuals who are self-loving and those kind of things. These people are now showing that they still continue to have those fears and held those stigmas. And now they feel, honestly, but they can say it more now than they used to say it. So I'm watching that. Also in the medical profession, so I'm going to give you another one a point of view. A number of the providers now who are showing stigma because they have fear of not being able to actually truly care for people with HIV. I would actually say that there was a time where there were more providers who knew how to handle this disease and deal with the new medications that are coming out and the issues related to keeping people alive for longer in the past than they are now. And I know that may sound a little strange because we have better medicines. But what I meant by them is more people who were physicians who were spending more time learning about HIV than they do now. So there's kind of a little bit of a fear amongst general practitioners, amongst people who are in rural areas who don't have a lot of experience with treating the disease.
Yeah, that's a great point, Dr. Virgil, and I thank you for lifting that up. I know we see very similar conversations, especially at the intersection of pre-exposure prophylaxis. You know, even though we have recommendations from CDC and FDA that any, provider with prescription access can write for the prescription for PrEP, we still see a lot of referrals going to infectious disease, and that doesn't have to be the case. So thank you for that. We'll go to Ms. Sandra, and then we'll go to Kevin. You're muted, Ms. Sandra. I don't know why. Is it? Let me make sure it's not me. Is it me?
Is that better?
Yes, yes.
Okay, thank you. I don't know how deep we want to dive into this particular point, but I think if I were to harness this conversation a little bit, I'd like to know who's getting it right in the faith community. That's a seriously untapped area. It's necessary that we start the normalization of HIV and conversations about HIV within the faith-based community. And if there are any individuals out there that have best practices, I think it would be beneficial to know what those are.
Thank you. Yes, yes, and I hope someone who is
Now we
out
can't
in the
hear you.
Zoom. I hope someone who's out in the Zoom land will put their hands up and maybe tell us some strategies that they've used. Their name may begin with an A and end with an L. Kevin, go ahead, please.
Hi, everybody. One of the things when we talk about the fear, and I think Dr. Virgil mentioned this, was about, the fear of dying back in the 80s and 90s. And so even with in current time, I've had patients and young patients after being diagnosed felt the fear of death. The first thing out of their mouth is that they're going to die. And I'm confused as to why they still feel that way with treatment options today when people are living longer. Where do they still get that fear of death? The other thing is that they have lack of family and social support. Is the first thing is I can't tell my parents, I can't tell my friends, so they lack support.
Yes, thank you, Kevin. I think we live in a community where we still see more than 800 people dying associated from HIV a year. So death in HIV is still a real thing. I mean, I know with our work connected to Thrive Support Services, anytime we did have guys transition as a result of HIV, it is taken serious, and it still happens, too frequent, to say the least. I saw Alfonso hand go up. Alfonso, you want to add anything, friend?
Hello, everybody. Good evening. Real quick, I just wanted to speak to Sandra's point in regards to some work that can be done around the faith-based community. I will say Vision Cathedral of Atlanta, led by Bishop O.C. Allen, they have a program called Prevention from the Pulpit, which I know is, they've been working on it for a while, but kind of some initial steps that they have done is actually create an HIV ministry within the church to create a safe space and create a space for people to be linked to HIV care within the church. So that has been very fruitful, and not just for treatment, but for prevention as well. So people that want to access PrEP, people that want to get tested, they were able to actually link folks through the church because that is a space where it absolutely needs to be talked about. And I have actually just done a presentation for National HIV Faith AIDS Awareness Day. It was very short, only about 10 to 12 minutes, but I'd be happy to share that with you if that would be helpful, just to kind of give kind of a guide on where people can start. But I completely agree with you that there is a lot of work that needs to be done, especially in regards to stigma, because the church has not done the best job at being a safe place for people living with HIV. So I would love to assist you or anyone else interested in however I can.
You know, we love taking in new PowerPoints that we haven't seen. So please, please share them, friend. I really, really appreciate it. But I think you hit the nail, you hit the nail on the head. I think that's the saying. But we definitely have to create additional safe and brave spaces for our faith settings. And I think we also have to be mindful in this relationship and situation that everyone may not come from a Christian or monotheistic walk of life. So just being mindful of providing additional breadth and reach would also go the distance. So thank you for that. So let's jump into some of these questions. So you see, the first one says, what causes HIV stigma within prevention and care across Georgia? So again, like, you can feel free to bring up lived experiences or even experiences that you've heard from a friend, as we think about how better can we create programming. The second one is dedicated to what are some activities that may reduce the impact of HIV stigma? And I think we're already hitting on some of those, but if there's other models, other, informed strategies that you've heard of, please also, we welcome those to the session. And that final one is what's working well and what can we improve upon? So anyone can feel free to start on any one of them.
Well, I'll jump back in here.
Come on.
So I want to talk about the second question here. What are some activities that may reduce the impact of HIV stigma? And this is not an informed strategy yet, but myself, along with Richard Hutchinson, who is the executive director of He is Valuable Incorporated, as well as Christian Dacus, who is the founder of Darkroom Media, we are actually collaborating to help end HIV stigma through media. So we are starting a network called This Is Your Moment Network, or Time Network. And I bring it up because one of our aims is decreasing HIV stigma within the Atlanta area initially. And what our goal is to create video content to play in waiting rooms around the Atlanta area, so that while people are waiting to get their HIV treatment or waiting to get tested, they're receiving educational and entertaining information about HIV. And I think it would be great if we could somehow figure out how we can connect with the Ryan White Planning Council and GPAC. I'm a huge fan of both of those organizations, but we want to make sure that the content that we're creating ties in with the work that's being done on a macro level around fighting HIV stigma. So just wanted to kind of plant that into this space. I'll put my email in the chat for anybody that's interested in kind of knowing more about what we're doing, but I would love to figure out a way to kind of tie in all of our goals together and resources to figure out how we can make this work.
That sounds remarkable, and again, even going back to that levels of HIV stigma table that we just showed, that's at that top of the table. Truly thinking about how do we infiltrate mass media messages to begin to contribute to changing the social norms. I think that's right on. Thank you for that. Dr. Virgil, you put something in the chat. I'm not going to read it. So go ahead and verbalize it for us. Okay.
Oh, okay. Yeah. Again, my observations have been fear and lack of education are the big components. So again, to me, education related activities of getting people out and getting individuals to know people who are or who are at risk for HIV and those who have HIV infection, those are that's the way we address it. So I just kind of threw that out there because again, it's amazing how many individuals now don't know, or people come to me, constantly. I'm at the tennis courts playing, or at a grocery store, and people know that who I am, that will come and ask me a question about HIV. And one question I'm hearing a lot is, oh, is HIV still out there? And, people are still dying from it, right? But we just having more people die from COVID. So again, I'm saying, wow, again, seeing that sometimes when you go further in removing the risk of death related to a disease, and I've seen this in more diseases than just one, being an infectious disease doctor. Sometimes you actually start having less education, and if we're going to deal with stigma, we can't have less education. So that's kind of why I put that up there.
I love that. Thank you, sir. Would you also, just thinking about the medical providers and knowing how important, all pieces of the medical team are when it comes to successfully treating HIV, what would be some of those, opportunities around reduction of stigma that we can specifically program for medical providers in your eyes?
I think that definitely in the teaching of the students, when they go to medical school and in their residencies and their training, they have to have that experience. They have to have the experience with individuals who have HIV disease, because I think that right there is where you catch it just at the very, very beginning. Because then when they go out in the field, they won't catch bad habits or bad ideas because they've already had that experience. I know this may sound a little off the wild wall, but when I was younger, my father used to say, when you go out and present yourself in a way, because sometimes people who aren't of color, who haven't had your experience, will never have but one experience, and that might be with you. So if you present yourself in a way, when they go out there and someone says, well, people of color are like this or like that, and one person will say, well, no, because I know a person like that, and that's not how they act. So I think you get what I'm trying to say. So addressing it from that standpoint of medical school and training is one. And then the other thing too is ensuring that, again, that a component of the training that providers continue to get as they go along has to have to do with HIV. I think that also will help address the issue, because as things are now, some individuals are able to gain all the required education that's necessary for their CMEs, et cetera, without even addressing the subject matter. And so I think that's one way we can also address it.
Got it. Thank you, friend. I really appreciate that. So I saw Jamila hand go up and down a couple of times. Jamila, you want to add something?
Well, you actually kind of covered it. I was actually going to say limited and lack of education in both the school system as well as amongst medical providers. I think we clearly see that there is a lack of comprehensive education just when we talk about sexual health. And so that is a critical component. We can't expect to address anything related to HIV if the only way we're approaching it is from a public health standpoint. We have to find ways to incorporate that, because when we're talking about HIV, it's typically in the concept of strictly HIV, right? We're not talking about it in the overall general health sense. And I think that is part of the problem. So when you talk about diabetes and when you talk about high blood pressure, you're talking about it in general. So you need to have overall good health. So if we're talking about sexual health, that should be within the same context. And I think that is a huge barrier, because we always end up in this silo of HIV is over here and everything else is over there. And so I think that, again, just ties also into the education level of just students in the general population, but also amongst medical providers. I don't know how many times I've worked with colleagues, friends who are in the medical field, and they're not even comfortable saying or using terms that are related to sexual health. And so if you're not even comfortable with saying words like vagina, then you're not going to be comfortable having a conversation about HIV. You're not even comfortable saying HIV or AIDS. And so those are things that I think are critical. We have to look at incorporating HIV as a general health component when we talk about education across the board.
Thank you. Really appreciate it. I saw Sandra's hand. Go ahead, Sandra.
Sometimes I wonder if we've kind of done ourselves a disservice with using the acronym HIV. And I have to kind of back into what I'm about to say by using this as an example. when the world was freaking out about oils and the use of different types of fat, Kentucky Fried Chicken decided to use KFC as their new brand. In some way that was supposed to help make everything healthier, right? Well, I almost think the same way concerning HIV, because oftentimes when people say and hear the word HIV, they think it's specific to a certain group of people, and it's not necessarily for them. I've often wondered if it would be more beneficial to this cause if we were to market this as what it is, a human immunodeficiency virus. And just to see if there was any traction that we would gain in terms of people really understanding that if you're human, you're subject to catching this virus and you need to pay attention.
Totally understand. Thank you, Fran. Kevin, go ahead, please.
Yeah, I agree with educating the medical community. I remember going to a urgent care for what I thought was a bad cold, but was the flu. And the nurse practitioner, when she did my medical history, and I told her about my HIV status, she said that, oh, I tell my patients don't take that medication and rely on God. And I was left just floored at her response, and I was just too sick to get her because the rage went up in my head. I could feel my head burning, but I was just too sick to, to correct her. But I just could not believe that a medical provider actually said this. And I can only imagine how many other people or patients she said this to. And in addition, I used to go to Spelman a couple of times a year for about 10 years to speak to a class there on students who were thinking about going into public health. And one of the things that I would always tell them is about how they approach patients and how their actions can cause damage to a patient, or their lack of education on how to communicate with patients, especially those living with HIV. And I just felt that that was a good start with students so that they would not go into this field blindly.
Thank you for that. Really appreciate it. One of the things, that I think some of the comments make me think about, especially when we think about the unequal impact that HIV have on certain populations, is the importance of data, and whether or not data is being understood and the level that we need it to be understood. So I wonder, do you guys have any thoughts or considerations around how can we better communicate about the impact of HIV across our state?
Hi, this is Zena. I was trying to figure out how to raise my hand. I wanted to give some feedback. Specifically, it was just interesting when you were talking that the reason why Anise was created, because when I got my master's from Clark Atlanta, they never talked about HIV. So when I did my internship at Outreach, I was clueless. I didn't know what HIV was. I didn't know anything about HIV. So we also have to look at making sure that they are culturally competent in behavior health. And one of the things that I did when Corona came out, and you know how everybody was ashamed of the Corona and didn't want to tell people that it was positive or who they think they got it from, I was saying this is the same thing happened with HIV. So I was able to connect the shame of the coronavirus with HIV when I started talking about the secrecy, shame, and guilt around my peers who think that they are invincible because you don't know who you touching, just like you don't know, who you having sex with as well. So I want to make sure when we talk about that, I was able to do the correlation with the corona as it relates to stigma with HIV as well.
Thank you. That I think that brings the point home of what we are calling syndemics, right? And syndemics is truly the complex layering. So imagine the different pandemics or epidemics as pancakes, right? Rather than having a short stack of pancakes, you can have a full stack. So when you think about HIV, when you think about monkeypox, when you think about, housing, all of those truly stack upon each other, and it places individuals at greatest risk or greatest vulnerabilities to come in contact with those things. I think all of those things are really, really important as we, move forward. So I saw some new folks join the session. Hello, and welcome to the conversation. We are truly talking about HIV stigma. Feel free to jump in at any point in time. We have some community conversations on the left-hand side of the Zoom, but feel free to jump in wherever you want to. We will include you in the conversation.
And
Tito, go ahead.
Daniel, yes, and I also wanted to comment as well. It's kind of number 2 and number 3, as far as activities that may reduce it, and it kind of bleeds into it. What is working well, what can be improved, is cultural competency. I always try to bring around back to that idea, because we want the clients, our folks who need the services, we want them to be able to get the services where they feel the most comfortable. That way they will come back and actually get what they need. And it sounds to me, based on what was just said about universities, that opens an avenue that perhaps, there's options to speak to university level folks to try to offer some sort of training of sorts. There was a prep for university program that I participated in. It was just a training. Basically, it's for universities to train them on how to handle and how to talk about PrEP to the students. If we could figure out some way to pull that in and create an overall HIV idea, then there's this chance that we could also educate them more. So it's kind of a twofold thing for me. You have cultural competency that we always need to continue to improve, but you also need education, provider education, if you will, we talked about last time, but also education to the point where we have people that are willing to discuss topics such as this.
Yeah, I think that's a great point to lift up. And I think even, the fact that when we think about the Atlanta University Center, the AUC, Spelman College has a brand new president, Dr. Helene Gale. Dr. Helene Gale was the director of CDC for quite some time. And she also led public health initiatives through CARE Incorporated, and since her transition from CARE, she's led philanthropic health equity work. So I definitely think, with new relationships, we can highlight some different conversations that we hadn't had the opportunity to do before. So thank you for that, Tito. It's really, really important. Anyone else? I saw Maria's beautiful face come on the screen for a minute and then it went away. Maria, would you like to add anything?
Thank you. That's what I prefer, not to be in the screen. Let me just, show my face again here. Well, first of all, I agree with everybody here. I do think that for all of us, who has been in this field, hold on, let me just put my dog on the floor. For many of us that we have been since the 1980s or 1990s, working in this field, I think that it is pathetic. It is pathetic that in 2022, we are still talking about the same themes about stigma. I thought, oh my gosh, I thought that was overcome so long time ago, but it didn't. Still we have many of the issues that we had before. What is working? Something is working well up to the point that now we are not talking about people dying of AIDS like we used to in the 1980s and 90s, but we are talking about people living with HIV. Picking on whatever, Jamila, mentioned regarding the causes of HIV stigma, I do think, that yes, just because, HIV, it is related to sexuality, HIV, it is related to substance abuse, or is linked to substance abuse, especially, injection drugs. Uh, that's whatever, make it even, harder to deal with, with a stigma. Because, to work, with HIV stigma, we need to work with a stigma regarding sexuality, with a stigma regarding the LGBTQ community, and with a stigma about substance use. So what's, some of the activities that may reduce the impact of HIV stigma? Wow, it is a huge, and deep, question. But I do think that we need to keep, putting the label. And when I say putting the label, sometimes, just by hiding, HIV, the name, just by, making sure that there's nothing, there that it says that this is related to HIV. I don't know if, up to a certain point, we are, supporting stigma in that sense. In order to avoid stigma, we are supporting stigma. I don't know if it makes sense, to you, Daniel.
No, it makes perfect sense. I think we always have those, especially those conversations at whether or not we like, and I think about mobile testing, right? Should we have a mobile testing van that's wrapped in a wrap that says HIV testing, or should it say health screenings? I think that intersection is crucial. I think you bring up the importance of an intersectional approach, and being able to provide more folks on ramps to this conversation than just only filtering through, men who have sex with men, or racial, ethnic groups, or even housing status. So I think all those things are really, really important. Thank you for that, Maria. Howard, you're on camera, so that means you want to tell me something. Come on, tell it to me.
Good evening, everyone. Good evening. I'm here representing Clayton County Health District. I am newly in a position as a community engagement specialist, which has been renamed. Actually, I'm an outreach specialist. And this conversation is so important because of some of the very things that we are approaching with trying to have events, with some of the things that we have coming up, and in the community of Clayton County is right now said unknown, that we know where our demographic is. So we're trying to approach it with the same conversation that you're having. It's stigma to hide HIV, but it's almost, excuse my French, damning to say that that's what we're promoting, because people go, oh no, I don't, that doesn't pertain to me. When in a sense, 3 out of 5 people, it may impact them, and they do need to come and talk to us. So we are trying to convey a message. If we combine health with HIV and put the wording up like that, that it may be more essential that people adhere to it than just having big billboards on 75 that say HIV awareness and nobody takes the time to get it. So we're still dealing with ignorance, and we're still dealing with fear of just wanting to know information and being brave enough to get tested.
Yeah, I think all of those things are really important. I think one of the things that we truly do not, I haven't seen enough conversations around is like how we visualize HIV. So I tell anyone to give me the first 3 colors that you think about when you think of HIV. Red, white, and black, right? And how stigmatizing those colors can be. Generally speaking, when we see red writing, it's as a result of you doing something wrong in English, right? Or we think about the trauma that red lights can, provide it's a spatial stigma conversation, right? It's truly called spatial stigma, but just thinking and being mindful of how deep stigma goes, especially when populations and communities just continue to be negatively impacted. So thank you for lifting that up. And welcome to Clayco. If you have something, let me know. I'll come down to our southern neighborhoods any day of the week.
Please help me out, because we have an event coming up September 27th, where it's National Gay Men's Awareness, HIV Awareness Day. And that's the first event that I've only been there 3 hours, and they pushed me in as the lead on this event. And it's the biggest event that we do. I'm like, oh my God, why would you do that? But that's what they did to me. So I have to shine. I'm going to do my best.
Please share it. Please share it. I think I'm in town the 27th, but if I'm in town, I will make a commitment of traveling down south to Clayco to see the festivities. Okay, friend?
Well, it sounds good, because what's really, we're categorized as rural. I don't know why, but Clayco is rural.
I mean, this is being recorded. I won't say what I feel about that. But I see in the chat, Reggie said, we need more heterosexual imagery in media, as well as persons with disabilities, so that we dispel the myth that HIV is a gay disease. Great points to lift up. I think that kind of goes back, to one of the questions that I was asking about data. When we truly look at the data, not only across our state, but much of the nation, we see oftentimes 4 out of 5 people who were diagnosed with HIV in any given year, maybe men who have sex with men. So my question, or, just for a quick conversation, how do we communicate those uneven burdens? I know that we will never be able to highlight everyone who is impacted by HIV, within our communities. But I'm wondering, what do you feel? How do you feel? What are some of the thoughts that come to your mind when we think about, just the disproportionate or the uneven impact when we look at specific communities? And Reggie, please, Reggie, jump in using your voice, not the chat box. Okay, Reg. So this means I have to send an email. Okay, friend.
No, I'm
okay,
sorry.
go ahead, friend. Come on.
Okay. Thank you. We're the man behind the curtain today. So yes, just a lot of imagery whenever folks that are heterosexuals or person with disabilities, a lot of the stigma is around, first of all, not wanting to be identified as being gay. So there's a level of homophobia that's still around. And but it's reinforced by a lot of the media imagery. And I think that, with all of the other great information and great ideas that we're trying to employ, if we're looking to end the epidemic, that we have to reach into every aspect of who's being affected. And it would definitely benefit us to see more imagery around heterosexuals and persons with disabilities.
Yeah.
Thank you, friend. Really appreciate it.
Our organization, being everybody's talking about organizations, the Reginald and Deion Smith Foundation, my wife and I was diagnosed positive in 1988, and she's still HIV negative. We've been together for 37 years. And so we know and come in contact with a lot of people that are in serodiscordant relationships and that are just dating. And, there's a lot of interaction that goes on as it pertains to heterosexuals. And and that definitely speaks to the persons that are affected as well, and the psychosocial issues that come into play there. So, we just really have to be mindful of being all inclusive to everyone. And we try to do that.
Thank you, friend. Really appreciate it. So I just look at the time, and of course, time flies when you're having fun. So if you just give me 6 more whole minutes, okay? Let's just wrap with what are we missing? Okay, within this conversation, you know, I think we've hit many of the questions, many of the prompts on the screen already, but let's wrap with what are we missing? And I see we have some new friends that joined us, Don and Rod. Hey guys, feel free to chime in anything that you know want to throw in for our conversation.
This is Rod. I just want to say hello. I was just chiming in quietly, but it's good to see some familiar faces in you guys. I hope everything is well.
So we asked a question about data. Since you're here, I'm gonna pose it back to you.
Sure.
What do you think, you know, from the place that you sit and just thinking about your history, how do we communicate data more easily for our most impacted communities?
Oh, the best way is to not, for us, for the state level, is to not be too technical. And be careful. We put out all these rates and we put out all these numbers, but that doesn't translate to the average person who's working every day and not in my field. So the most important thing for public health messaging is to I guess to be able to be interpreted by the general public, by majority of the general public. And so when we put out these data reports, I don't expect a grant writer and a person and a regular person that does something in a totally completely field, a completely different field, to be able to understand that same report. So it's best these fact sheets and snippets, short versions of the data and short messages from the data that that sends messages to those communities would be the best way. So, you know, let's just say 9 out of 10 people drink Coke and Sprite. You know, well, and it's a rate of so and so or what have you, and you could just say majority of the people drank Coke and Sprite. You know what I mean? You gotta communicate it shortly. They're not gonna read no long 1 page. They're not gonna read no 50-page report. They don't read that stuff. You know, that's not for them. And so, you know, you get the take home messages from those reports and make them smaller and send them out.
So you're saying people don't keep the surveillance report like right here, ready to go? Okay, got it.
No, at least not the majority of not the people that you want to send that prevention message to.
Got it.
Yeah,
I will remember that. Thank you, Rob.
Yeah, exactly. So those we know. I mean, we should know that those reports are for you guys and help support your work with those individuals.
Got it. Thank you.
And
Really
Daniel, real quick, just to kind of, you know, piggyback on Dr. Rodriguez here, I wonder if there's a chance, opens a door for us to get creative with the data messaging, you know, get creative with it. I don't know, like a booklet or something that has, you know, to make it easily more understandable. Like Dr. Rodriguez said, you know, sheets with data for the general public, they don't know what that means. They just see numbers, but they don't know what that means. If we can get creative with it, you know, like a brochure of some sort with like pictures here and there, because at the same time, remember, going back to that cultural competency, we want to meet people where they're at. And we may have folks who maybe have not had the chance to get to the point where they, or maybe not had access to the resources to get to the point to where they can read a data sheet and understand what's going on. So I wonder if there's a way that we can, going forward, kind of get fun with it. You know, I know there's limitations for us at the state, as you know, for those of us on the line there with the state, but I wonder if there's a way to get around that, to kind of get creative and fun with it, to make it understandable.
Yeah, I definitely think so. And, you know, I mean, Alfonso is chiming in the chat, but some of the things that I've seen definitely is just like 10, 15-second videos, you know, so rather than always having something print-based, having a video saying this is what this means, for additional impact or additional information, go here, using those types of messages. I know even within the MMWR, the Morbidity Mortality Weekly Report, about 3 years ago, they started putting a gray box at the upper right-hand corner, and it's 3 bullets about what you're about to read. So those types of literacy, public health literacy, norms, would definitely go a long way. Zena, you want to add something, friend? Oh, you're muted. See, the Zoom doesn't want us to be great. Okay.
Oh, I had to find it. It's a recovery day. I was just speaking on where storytelling, a lot of times, Kevin could really vouch for this. We do a lot of storytelling when we're doing statistical information for populations, specifically when we talk about children. We do storytelling when we are actually doing data. So I'm thinking when we do data, if we could do some type of storytelling or something where we comparing with a person who's actually HIV positive, that's outside the norm that we always show, and then we connect those data to storytelling. I think that'll be an impact and be culturally competent to particular populations.
Got it. Wrote it down. Thank you for that. Really, really appreciate it. Okay, so you guys already did what I asked you to do. You gave me 5 more minutes, so I'm gonna say thank you, thank you, thank you. Vivian, can you show the beginning of the presentation? Because next week we are here one more time. Next week's discussion is at the intersection of HIV and housing. Truly when we think about the structural and social determinants of health, so those big drivers of epidemics, we have to be mindful of how housing plays in that conversation. We continue to see across the nation that people living with HIV who are unhoused, have more than a 27 times fold with not being alive by the end of that year. So, we have to sit down, have a discussion about housing and HIV specific for our region. I see Don's beautiful face while he's driving. Don, turn the camera off. It's not safe to drive and talk.
Yeah, sorry, I stopped. That's the reason. I've heard everything everyone said. It's great. I agree with everything. I really do, especially the storytelling. We did that a few times at engagement sessions during GPAC several years ago. It was quite effective, actually. I remember the story that Dorothy gave from Columbus, and I gave mine and she gave hers. And of course, she looks like someone's grandmother. And nothing like what I look like, but we actually share the same story. And I thought that was the best way to tell that about statistics in so many ways, because it involves everyone. But we also, of course, in the Augusta area, it is so unfortunate that through all the years that we are still struggling with this issue really a lot. And we've come some way, but it's still a road uphill for us, I'm afraid.
Oh yes, we still have a little ways on the journey, but I think about what the older people say, I'm not yet tired. So we will be here to do a little bit more work. Join us next Tuesday, September the 13th. Alfonso, go, you're go. No, okay, all right. Join us next Tuesday, September the 13th, right back here at 6:30 p.m. Do me a favor, good people, okay? We've been sharing this flyer. Please, please, please invite someone else out to the conversation. After next Tuesday, we will have one more session, and that last session is dedicated to PrEP in the community, okay? Feel free to contact us if you have any questions, feedback, ways that we can do this better. This is a living relationship, so please let us know. Even if you want to have like 1 or 2 side conversations with populations that you specifically provide services to, we want that to happen as well, you know? So again, in closing, I thank you, thank you, thank you. I look forward to seeing your faces next Tuesday. Have a good night, be safe. Remember to wash your hands and go get a booster. Like, yeah, just be safe. Public health all around. Good night, everyone.
Good night. Take care.
Good night.
Good night, everyone.